Right, good evening everyone. I'm not really au fait with this platform as such, and I can't see myself or anything, so I'm just going to go for it and hope everything's coming through. My name's Doug Watt. I'm a dentist in Leamington Spa, and I've been working going on to the next I've been working with the IDDA for a couple of years since it started, doing a few lectures and things. I'm just having a few issues. It's not going on to the next screen. Here we go. So what I'm going to be talking tonight is the integrated digital practice and how we've set up our practice to use digital technology, and what we've been doing recently and how we've been trying to improve things within the practice using more of our digital tech. So we have got a lot of technology in the practice, and we really sort of embraced it and gone all out, and we're using scanners, printers, mills, everything really to do as much in-house as we can these days. So I just want to run through a bit of basic stuff about digital and how we've done what we've done and where we are now. So firstly, main benefits of getting into digital, I think, are the predictability and control you get from using this technology. It does make fits of crowns, occlusion much better, fewer remakes, things like that. For the patient, the efficiency of chairside same-day dentistry, and for the dentist, that efficiency can be very useful, and I'll cover that a little bit later on. Retrievability, in that you have really great patient records of the scans at the patient's initial consultation, and also if you've done a crown, you have prep scans, and all those scans you can always go back and see what you've done. And also, if you say you needed to re-mill a crown, you've got that file, you can go back and do that. And it's fun, so job satisfaction, and the patients seem to be very excited by the technology and seem to think their dentist is doing the best they can, so that's good from both sides. I put this quote in, I like this quote from Charles Darwin, just thinking about adapting to how things change in the world of dentistry. So the quote is that the strongest of the species survives and not the most intelligent. The strongest of the species and not the most intelligent survive. It's the most adaptable to change. And I think with the changes that are coming in dentistry and the digital technology, if you're not getting on board with it at this stage, then you could well be left behind. And that's why I think being adaptable to change is a really important thing when it comes to digital technology in dentistry. So before you want to consider setting up a practice with a lot of digital tech, what you need to think is what you actually want to do, how involved you want to be in that technology. So you could just scan and send to the laboratory and let them do all the digital wizardry on the lab side, and then mill crowns, and then you just fit them when they come back, and that's fine, in which case you can go with basic intraoral scanner and just start doing things that way. You can consider doing things like implant guides and printing them. So we started with the scanner and then got a 3D printer and started using 3Shape Implant Studio. I should say most of the stuff I'm showing is related to 3Shape because that's what I tend to use in practice. So yeah, we started designing and printing our own guides and doing guided surgery in-house. We started that probably about 2.5–3 years ago, doing the in-house manufacture of those, and now pretty much every case we have a guide for, just because it costs us a few pounds to make, and it just adds that level of predictability to our implant placements. Then you want to consider if you want to get into chairside or in-house manufacture, which has been around for a long time, especially with the sort of early CEREC machines and things like that. It is sort of quite an outlay to get into that, but there are big benefits to doing a lot of the manufactured crowns in-house by yourself. So this was a case, one of my first in-house cases, and I wasn't quite trusting on the contact areas, so I 3D printed a model. But yeah, now I don't bother printing models. I find that the fit is brilliant, so I don't need to. And then consideration of things like in-house orthodontics. So I don't do any orthodontics. I don't pretend to know a great deal about it. This was a case put together by Vinny Tandy, who I work with. So you can see sort of there's a CT scan and aligning the CT scan for the ortho planning, digital scans of the arches, and then 3D printed models. We've also got a simulation of the treatment outcome down at the bottom there. So that's a nice feature to give you an idea of where you're going, give the patient an idea of where they're going, and be able to utilize the digital for orthodontics using in-house technologies as well. And there's a few different pieces of software that you can do that with. Then this, again, a bit more about orthodontics, so indirect bonding media. So we sort of decided where the brackets were going to go, or again, Vinny decided where the brackets were going to go, but then we print out a model and printed out a custom bonding tray. That kind of stuff just makes things easier and quicker, which a lot of the time digital dentistry should be about making things easier for you, not necessarily quicker, just easier and more predictable. And then finally, digital mock-ups, something we've been doing quite a lot of in the practice. So we sort of mock up where we want the teeth to be beforehand. It's useful because it gives us an idea of where we might have pitfalls or problems going forward, and let us plan how the treatment's going to go before we start, which we start with the outcome in mind. So this was a case where I'll run through this case later, but we did some digital mock-ups, then did a 3D printed model, Memosil matrix, and then transferred that to the mouth. And I'll show you how we did that as I go further through. So the other considerations for going with a sort of more integrated digital practice are the cost implications. So chairside versus laboratory fees obviously is going to decrease your laboratory fees because you're doing a lot of the work in-house. Your patient demographic as well. So if you're doing a lot of ortho, then it's really a no-brainer to get some kind of digital workflow to do that. If you're doing a lot of crown and bridge, it's a really good idea as well. And to be honest, now you can do whitening trays very easily with scanning, so I don't think there's any reason now with any patient demographic or treatment that you're carrying out why you wouldn't want to go digital. And then the other thing for chair side, I think availability of the dentist and diary zoning is something you need to consider, because although I do chair side restoration, sometimes I get reception coming back to me and saying that they can't get the patient in for a chair side restoration for another 6 weeks or something, but I could have 2 separate appointments, and then they could get them in within 3 weeks, and in which case sometimes I don't get that same day chair side thing. So diary zoning to make sure you've got the spacing to do that kind of stuff is very important as well. So it does change a little bit the way you think about treatment and treatment planning. And then I'll just put a few slides in of other things we do in the practice, and we do most of this stuff again in-house. So things like crown lengthening, surgical guides, cases. Well, this wasn't done in-house, but the digital makes this a lot more predictable. I would be scared of getting silicone locked up into that hole in the patient's hard and soft palate if I was taking a conventional impression of that, but as it was, I put off doing that until I got a scanner, and then it made it a lot easier and less scary to do that case. And then digital smile design. Now this, I love this picture. It was I live in Stratford-upon-Avon, and this was a photo e-fit put out by the police in West Midlands for a burglar who was active in Stratford, and I just think it's a brilliant advert for DSD. I wanted to put this in here, it's again something a bit more interesting. So there's a program called Invisalign that lets you turn STL, make STL files from DICOM files from a CT scanner, and I've used this recently to do a case I'll show you in a second on digital smile planning, and then we did a crown lengthening surgery case based on that, knowing where the bone was related to this CT scan. The reason I put this slide in is we've got you've got different voxel sizes you can export a CT scan as from most of the CT scanning units, and this was just to show how much detail you lose as you go onto the 0.4 and 0.5 voxel sizes. But if you go at the original size of the CBCT scan and try and convert that, you end up with a huge file. So 0.3 seems to be the sweet spot for doing that. So that's just something I did recently, which is quite useful and made working with these files a lot easier. So this is the case again where we've used the CT scan, exported an STL, aligned it with a surface scan, designed crown lengthening surgical guide, using that as a special tray with a 0.05mm offset, traced out. I did this in two pieces of software. I did in Implant Studio where I could see the CT scan very clearly aligned with the surface scan, and then I had to go back into a different piece of software, the dental systems, to align the STL and design the guide. But I could measure everything and work out exactly where I was going before I started. This isn't the only reason I was doing it this way, is because I wasn't going to be restoring the teeth, so I wanted to know exactly where the bone was and the enamel was before I started. And then this is the case, just you can see lower left there, the crown lengthening guide in place, gingivectomy, reflector flap, and then that's where we ended up with the, and we knew there was enamel, we knew where the bone was, and we knew exactly how much we had to remove before we started. So what you'll need to go for a fully integrated practice, it very much depends on what treatment you want to be carrying out, whether you're going to be doing implants, CT scanning, just restorative, wear cases, and all these different bits of kit coming really useful. I'll try and go through a bit of information on each of these as we go along. So we'll start with how I initially got into it. So I got my Trios scanner about 3.5, was it 4 years ago now? Can't even remember. And we used that initially just to scan and send to the lab. Then we introduced the Implant Studio software and the 3D printer and started doing the in-house surgical guides. And then we had a load of old study models up in the loft. So we got a model scanner, which came with the dental system software, and we started archiving the old study models to free up a lot of space up in the loft. I say we, my nurse did a lot of that. And then we used the dental system software to start doing our digital mock-ups and our crown designs, and then got hold of the Roland DWX42W wet mill when that came out, and started producing our crowns and inlays and onlays and cronlays, and would export that from dental systems into a CAM software and then mill it. Then we moved on to a slightly different way of making the crowns, which was using the Trios Design Studio, which has got a direct link to the mill, so you don't need to go through all those stages of exporting the crown design into a separate CAM software. So it's more like a CEREC workflow where you design it directly and it pings straight off. And then more recently, right before we were locked down, we set up a new IT system with high-powered desktop and a client server install. And I'll go through why that's beneficial and what that's helped us do in a minute. So obviously, lots of scanners on the market presently. There's Trios, Trios 3 and 4, and there are good reasons why you might go for one or the other of those. Trios 3 can still send to Invisalign. Trios 4, they've blocked that happening. Trios 4 is really good, especially for wireless scanning, because you've got the automatic heating tips on it. Trios 3 is very good for wireless or wired, but the wired version heats more quickly, so it's ready to scan more readily. Then obviously CEREC, Omnicam and Prime Scan, the iTero from Align, and yeah, there's a few to look through. So it would be worthwhile looking into all of those, getting reps to show you them if you haven't started scanning already, and make a decision which one will fit best with what you want to do in practice. There's a QR code that you can just put your phone camera on there. That's a review of scanners from the IDS show in Cologne last year, and that just runs through pros and cons of all the different scanners and what they can do. So yeah, that's worth looking at. I'll leave that on the screen for a moment just so you can scan it if you want to. Right, so all of the scanners work a little bit differently and they have a different scan strategy, and that's something that you'll be taught when you first start with it. But obviously here we've got the Trios 4, which I've been informed looks like a killer whale. The Omnicam Prime Scan, sorry, CS3600. So all the scanners look pretty much the same, just slightly different designs on each one. When it comes to choosing an open system, this has become less of an issue over the last 18 months, 2 years, since everyone started allowing STL exports. It used to be you couldn't actually export the files, and there are still some degrees of closeness to the systems, but actually they are getting a lot more open and things are improving. So benefits of the closed system is obviously you can send it to any lab you want. An open system, do I say closed? You can send chairside to any mill, and I'll show you that the Trios has set connections to certain mills that are trusted and work really well. Integration to other systems is a biggie because you can do things, use different implants planning softwares. If you can export that surface scan of an STL and whatever CT scan data you can get out of your scanner, you can import it into whatever open implant planning system you want, and there are loads out there now. And then you don't have to worry as much putting new equipment in. It'll work with the old equipment because it is open. One thing I would say on putting new equipment in is if you are on one workflow, so you're working with, say, Trios or Serec or Carestream or any of those, it is usually easier to work within the same workflow in that they talk to each other very, very well. So if you are with one set workflow, it does make sense to stick with that if they've got the kit you want, but you can swap and change. So with the Trios, we've got now two options for how the Trios integrates with the software. You've got the Move Plus and the Pod. There's still the Trios wired and wireless on the Trios 3, and then the Trios 4 it's both wired and wireless, in that there's a cable that plugs into the back of it to wire it in, or you can use it wireless. And then there's the Trios Basic. The Trios Basic scans to exactly the same level as the Trios 3 and 4, but you don't have any of the patient monitoring, treatment simulation, smart design, and patient-specific motion features that you get on the Trios 3 and 4. And there's videos all about that on YouTube, so you can find out what each of those do if you're interested. And you can still integrate it with any of the other apps like Trios Design Studio and Implant Studio. So I have got the Trios Move wireless version 3, but we've recently changed the way we're doing things in the practice, and I'll run through that. This is what's called the Client-Server Setup. And then looking at computer-aided design softwares, you've got a load of those as well. So Serec InLab, the Dental Wing software. The two that I'll mention here from 3Shape, which is Dental Systems and Design Studio, and then Exocad Chairside, which is Exocad Chairside, which is now owned by Align. I bought that a few weeks ago. So this is a bit of information on the different softwares from 3Shape. So on the left-hand side, they've got the different studio apps, which are Design Studio, which is for your crowns, bridges, and veneers, and now screw-retained crowns on implants as well, on tie bases. Implant Studio, which is the implant planning design. You can do two versions of that. There's the Implant Studio Planner, where you just plan the implants, send the position of the implants to a lab, then they can design your guide and print it or mill it. And then there's the Full Implant Studio, where you design the guide as well. So if you're going to do in-house manufacture, you don't want just the planner, you want the full version where you can design the guide. Splint Studio, which is great for designing your Michigans and Tanner splints, and then Clear Aligner Studio, which allows you to design models to print, which you can then do vacuum formed aligners on, and then the Indirect Bonding Studio, which is what I showed earlier. And then on the right hand side we've got all the different indications from Dental Systems, which is the full lab software from 3Shape, and you can do pretty much anything on that. It's got sort of massive variability on what you can do, and you know, I've barely scratched the surface with that software, but it's a good piece of software, and if you know how to use it, it can work very well. So looking at mills, now really you've got 4-axis and 5-axis mills. You've got loads of different materials. You've got different levels of openness. So the most recent mill is this prime mill, which mills a crown in 4 minutes, I think it was, and that's obviously the CEREC one. And then speed of milling obviously comes into it there. The Roland one, depending on material and the degree of detail, you go for mills anywhere between 20 and 25 minutes. I know the CEREC ones are around 10 to 15 minutes, and then the prime mill apparently 4 minutes, which is crazily quick. So this is when you've got the Trios connected connections, the trusted connections from 3Shape. These are the mills that are on that. So there's one from Straumann, then Arm and Gerbach, I think that one is, and the VHF one. I've got the DW42 DW42W, and then there's the new PM one, which has just come out from Roland. All of them apart from the Roland one seem to have a built-in compressor. The Roland one, you need a separate compressor, so that's something to factor in if you are going to look at getting one of these mills, whether it has a compressor built in. This is a chart of all the different materials you can use in it. So currently, as you can see, the PM1 can do Emax, Empress, and Tetric. The DWX42W has just been announced that it can now do metal milling, so we can start doing our custom abutments on that. And then, yeah, different ones are coming or have been validated, so that tells you all the options there. So before I got this direct connection to the mill, it used to be, as I say, you design, you'd have to export an STL, you'd save that, you'd open that in a separate piece of CAM software, you then import the STL into that CAM software, choose your mill strategy, manually nest the restoration and send it to the mill. But since this trusted connection, what you get is a design stage, automatically nests it. Sometimes you need to put the sprue in a different position if it's in a bit of a odd place, produce it and then send it to the mill. So there's a few clicks to get it to mill now versus lots of sort of moving files around before. So this is just a video of how of a design that I did on Trios Design Studio. It's improved slightly since this was done, and the margin detection is a little bit more intuitive now. So you select your margin, adjust it. I realised how picky I was getting, but there's actually microns that you're actually dealing with. And then that's the HD photo overlay you can take with the Trios, and that helps you pick out the margin much more easily, having that, especially if you're paragingival, so you can see where the margin is in relation to the gum, because you've got that HD overlay, so it gives you a bit more colour definition. And then this is the contact points. So I tend to set this at 0.06 of a mil, just because I find that gives a nice contact where the floss clicks through, but it's not too tight that you can't seat it, and the patient doesn't get food trapping. So that's what I tend to use. And you have a set of tools that you run to get the contact points correct and the occlusion right. And then you can run either a virtual articulator, or in this case I've used patient-specific motion, which is a video of the patient's actual movements, that then once you've run that, you can hit to adapt the design or remove any areas where that's catching in lateral excursions or anterior excursions. Once you've sort of finished your design, checked it over, you're happy with everything. I'm fapping on this one. I redesigned this with the most recent piece of software earlier, and it was 2 minutes I think it took. and then you choose which sprue you put into on the roll and mill, choose your definition, which material, set it off to mill, and then mills it into a blue state, and you get actually your final crown, which then goes off for staining and glazing. And then I tend to run through this bonding procedure using rubber dam, and I'll put, I can't remember if I put a slide of that in here, but yeah, so then bond under rubber dam, and that's done. So that was the same day crown. Yeah, I wanted to do that one, but patient wouldn't have it done. But that was sandblasted in nicely, so that's good. So other things to consider on this, mill maintenance is a biggie, especially with things like the roll and mill. You need to make sure that that's looked after, the burrs are checked, the fluid for cooling, it's done every so often and it's kept clean, otherwise you'll get scale and build up, which will make you less efficient. A lot of that is done by our staff, so we don't have to do a lot of that, but it's just having the right training place to get that done. And then logging of your maintenance as well is important. As boring as it sounds, it's good to do that just so you can keep an eye on when things have been done and how quickly your burrs will wear out and how many crowns you can get out of them before you need to change the burrs. And stocks of blocks of material. So if you're in a relatively small practice, you're not going to want to have every block in every shade and size in stock, because you won't get through some of them. So it's worthwhile considering when you're planning a crown or an onlay to take a shade at that point and order the blocks in, so you know what you've got the right material for the treatment you're doing that day. So a little bit on staining and glazing, well, not really on staining and glazing, just on ovens. I've just put a slide in to show these two options of ovens you can go. So you've got the CS3 and the CS2, which will be fine for Emacs, and then the CS4 and the Speedfire, and I'm sure others can be used for zirconia. So again, certain mills will do zirconia and others won't. So the Roland one doesn't do zirconia. I know Serec will do zirconia on a block, and there are different mills will do different things. So just get the one you know you need, because there's no point going to CS4, which is about £7,000, I think, if you don't do any zirconia, because there's no point, you won't ever use it for that. So office setup. So recently we changed how we've done this, and the things really you need to consider. We're in a big old building on the surgeries are on 4 different floors, so we need something very portable and to be able to move between surgeries very easily. We've got we've got three Trios scanners and 2 Serec scanners in the practice, but the Cerecs are movable between the surgeries very easily. The Trios is on the cart. It wasn't. The move's a lot easier, but there's ways around it, and some very good setups you can do now to avoid needing to move big piece of kit around the surgery. You need to consider who will be scanning as well, because if you're going to be doing scanning with treatment coordinators in their treatment coordination rooms, which I wouldn't advise, but if they can move a camera around very easily and use a free surgery, that's a consideration. What you'll be using it for is also a consideration, as I said earlier: ortho restorative, smile design, patient motivation tools, patient monitoring tools. So that can all be very important in which scanner you go for, based on what that scanner will do. So something to look into and think about how you work before you pull the trigger on buying a scanner. And do the scans need to be widely accessible by everyone? So might be a consideration, say in an ortho practice, where someone, if the orthodontist is doing the consults, but then therapists are doing a lot of the work, having access to all those scans would be very useful throughout the rest of the building. So the setup type we've recently done, we originally just had the dongle and the Trioses and moves, carts, what have you, and basically the Trios camera was connected to that computer. It had a dongle in, and it could only work with that computer. What we've recently done is what's called a client server install, where we've got a master dongle, which is sat up in a computer on the top of the floor of the practice by the mill, We then reference that dongle from our desktops in the surgery, and that means that we have one license for Implant Studio on there. Anyone can use that license on any of the computers within the practice, reference that dongle on the top floor. So we don't need to buy a license for every computer. Also, with the new way I've set it up, this is what we've got set up as desktops. So we've got high-powered desktops in all the surgeries where the dentists are working. So they're i7 9th generations with a lot of RAM, very high-spec graphics card, SSDs in them, so they boot very quickly and the data transfers very quick. This TP-Link AC 1900 Wi-Fi adapter is there's a reason I put that in specifically, and I'll show you that in a second. So what you can do, and I didn't realize you could do this until I started doing it, is you can use a wireless Trios camera and you can connect it to any desktop with one of those TP-Link cameras in and reference to a dongle. So if you just take literally the Trios camera and one of these dongles, you can scan in any surgery just by moving the wireless camera around. And the TP wireless adapters are about £40, I think. So you can buy one of those for each of the computer desktops in a surgery, plug it into the back. You can connect your wireless camera to that. It'll reference a dongle in a server somewhere else in the practice, and you can just scan in any surgery just by moving that wireless camera around. You can then design directly on that desktop and send it through that trusted connection straight to the mill. So it makes everything so slick. So when I was doing one the other day, we scanned this shortly after we set it up. We scanned it before the patient even left the room. I'd had the crown designed, and then it just goes straight off to the mill, and you can send someone to put the block in, or if you've taken the shade early, you can plan that and have the block ready nested in there, and send it straight off. And then, yeah, being able to use those studio apps, so Implant Studio, Clear Aligner Studio, Ortho, Bonding Tray, whatever that one was called, and the Splint Studio, you can use any of those on that computer. And as long as you have the client points on the license, you can do it. If you're going to be using multiple Trioses, you probably want multiple client points, which is the seats almost on the dongle. Otherwise, you can only use it to scan in one room at a time. So that's something to consider. But it is good to be able to just move that camera around and not have a massive cart to move everywhere you go. So this is a TP-Link thing. So that just plugs into the back of a desktop, and then the wireless Trios will connect direct to that without any other bits or pieces that it needs to plug into the computer. The other way of doing it is you can use the desktop, which one of my partners is doing, and he's using that along with a Trios pod. So he's got a pod plugged into his desktop, which then the Trios sits by his chair, and he scans directly to that desktop again. So it's all the same functionality, it just doesn't have that wireless thing. But I think especially with the Trios 4 and the Trios 3 wireless, this is a really good solution. It means you don't need one scanner for each surgery, and you're not carting laptops or huge computers around all over the place. So yeah, the other thing is the scans are stored centrally, so you can then get those scans from any of the computers that are linked into that client server install. So if I scan in my surgery and then I want someone else to have a look at the scan, for example, if I'm doing an ortho case and I want one of the people in the practice doing ortho to have a look at that scan, they've got that scan automatically, and then they can use that just to send off to Invisalign or whoever they're using for the ortho. And yeah, as I say, you don't need multiple licenses as long as you're not going to be more than one person using at a time. So something like Implant Studio, you probably don't need more than one license, but for the actual scanning software, you probably would. And yeah, it's really efficient for the same day dentistry. As I say, you just scan, design, straight off. So I'm just going to run through a few other things we're doing in the practice as well, because chairside manufacturing and implants are things there, but obviously we've got the 3D printing side of things as well. So digital mock-ups and how you transfer those to the mouth. So you've got things like this, which is a direct to indirect veneer case. So I did a DSD mock-up. Probably didn't need to do that, but this was when I just finished the DSD course and I wanted to have a play with 12 o'clock photos and all the bits and pieces. So I then did a digital mock-up using that, did a 3D printed model of the mock-up, did a Memisil impression over the top of that, and then using some PTFE tape, filled that with heated composite, put it into the patient's mouth over the PTFE, cured through the Memisil, and made a little veneer, and then did that on both sides, took it off, trimmed out any excess, and then bonded that back on with heated composite and polished that in the mouth. And that was a quite neat way of doing majority of the work outside the mouth for some composite veneers. I put a little bit of surface characterization and hypermineralized bits on, and that was immediately post-op. And then 2 years later, all that surface stuff's gone, so that's probably pointless. But yeah, it made me feel a bit artistic when I did it. Injection molding. This was a case of posing a denture, which is why I chose to do it. I only really put this in. These two furthest posterior teeth were actually crowns we designed in the practice. The one on the patient's left was too big to fit in a block, so I ended up having that milled in wax and pressed in Emax by the lab, and the other side I milled in house, and then we injection molded that all off a digital mock-up of the front, just because he wanted to improve his smile, but didn't want to spend loads, and it was, say, opposing a denture. And then a few other bigger jobs, so things like long-term temporaries with PMMA, implant temporaries, and customized healing abutments you can do with the in-house manufacturer. So this was a case I just wanted to have a play with to see what we could do. So I copied the patient's existing teeth, and then we did in dental systems a merge to pre-preparation scan. So we scanned beforehand, prepped the canines, scanned afterwards to get the preps, and then used the pre-preparation scan to merge the design to that. So we basically copied the patient's existing teeth into the design, and the patient's existing teeth still looked rubbish, so we then tried moving them to see if that would make it look any better using their existing teeth, and it didn't, so we just redesigned the whole thing. But it was just an interesting process to see how we could copy the patient's existing teeth and try and reuse them if we could, but it wasn't any good. But we did reuse the canines, so actually canine guidance and the shape of those canines with wear facets and everything were maintained. So the final result is, not the prettiest, but it's a temporary PMMA bridge milled in house out of a B40L block of PMMA, and we copied the shape of the patient's existing teeth here, the canines, and they copied over pretty nicely. So actually there was minimal adjustment for the guidance there. Then a few thoughts on 3D printing. So the things you can do with 3D printing is obviously models, printing your temporaries, digital wax up and mock-ups, printing of wax for investments, implant surgical guides, the crown alignment guides which I showed earlier, special trays, indirect bonding trays, and occlusal splints. I'm not overly enamored with the occlusal splints. I find they tend to break, so I'm not printing those at the moment. I think still they're better off made in traditional fashion until a slightly tougher printing material comes out. Might be there is a better one, but I just haven't found it yet. So this is a case where we did a bit of everything. So we designed the implant positions on Implant Studio, placed 5 implants, let them heal, took the remaining teeth out, and then had a set of Atlantis abutments made for an immediate placement bridge. So I printed the model in-house. The designs were made on Atlantis. I then sent the model back to the lab. They fitted the Atlantis abutments and the analogs, and then we had a moment of truth where I had to take the teeth out, put the abutments in, and hope that. And we 3D printed a temporary bridge as well. Yeah, that moment of truth where the teeth was on and it had to fit, and it fitted. So that worked out well. The temporary materials for 3D printing these bridges aren't really strong enough for this yet. So I would consider doing again a PMMA one for that now, whether you break it down into sections and mill it out of blocks, or whether you get it milled out of a puck if your mill's up to that, or sending it to a lab. That's up to you, but yeah, and then a bonded bridge to finish that off. And then this was a case we did in the practice, which was quite a big case. We did Invisalign for this. I, as I say, don't do ortho, so Sian Mulligan, one of the people doing ortho in the practice, did this. So she did the Invisalign. I took out all the teeth that couldn't be saved, then temporized what I needed to, went back and built it all up again using digital, playing implants with Implant Studio. So we did 2 implants and some bridge work, a load of zirconia crowns and straightening, a little bit of everything. So it turned out quite nicely in the end. The patient was very happy with the final result. So yeah, I just like to put this in down, because irrespective of how many gadgets and digital you've got, if your patient wants to bite like that, they always will, and you won't get the right bite. So yeah, that's always something that gets me. Right, that's all I've got to say. So thank you for your attention, and I'm now going to try and work out how to turn myself off.
Doug, thank you very much for this really lovely presentation, and thank you for sharing your experience with 3Shape and how you utilize digital technologies in your practice. I think all of us will take away something from this. It's wonderful to see the nice work you're doing, and thank you for sharing that with everybody this evening. If you have any questions, ladies and gentlemen, please just post them on the chat, and then Doug can answer them. Doug, there's a question here for you. Can you please go through your composite veneer case again with the PTFE tape? Okay, it seems we've lost Doug. Doug, share it again, no problem.
Right. I'll just see. Can people hear me? Okay, I'll just see if I can get this back up on here, and I'll just run through. So it was the case with the composite veneers and the IDS thing, wasn't it? So the IDS QR code. I'll pop that on there. Okay. Is that okay? You got that?
Thanks very much for the lecture, Doug. Great lecture as
composite
always,
veneer bit,
and
some amazing
tips there. I think the one with
we go.
the wireless adapters for the Trios was, to be honest with you, I've never heard that before.
The composite veneer one. What we did was we did a digital smile design mock-up just to show where potentially we were missing a bit of tooth structure and bulk on the teeth, and that's shown on the 12 o'clock as well, that you can see there's quite a lot of they sit in quite far, so you're not got as much bulk as ideally you'd like on the incisal edge. So we used the DSD mock-up to show us that, and then you can use the DSD mock-up aligned now with your surface scan.
Can you hear me,
or your lab can do this in dental systems using what's called the real view engine, and then they can drag the design out to fill that DSD mock-up, so it fills up the gaps where you've got the outline of the teeth, and then you can get a 2D to 3D mock-up there. So then once I'd done that, I did this myself on the software, so I was just, when I was still learning it, so we then 3D printed a model in-house and used that model to make a Memosil mock-up in a Memosil matrix in a clear tray. The way I've done these since is I've just printed a before model and the digital model mock-up, and then used the PTFE on the model and just done it on the model before the patient even comes in, which means you don't even have to mess around with doing things in the patient's mouth. So what I do now is do this stage on the model, so put the PTFE on there, use heated composite inside the Memosil, seat that onto the model, or in this case in the patient's mouth, and then light cure it on there. So you then get this little composite veneer, which is the difference between your digital mock-up and your patient's actual tooth. So you then get this little veneer, you can then trim off any excess on that, place it back into the patient's mouth, and check it all fits, and then fit it in place with heated composite. So it's a one homogeneous mass of composite basically. So you sandblast it again, you can rubber dam, you can do whatever, sandblast the tooth structure, go through your normal bonding protocol, use heated composite, seat that, and then you're not messing around trying to use composite to build everything up. You've got the majority of the tooth built up already. You use the heated composite to then seal any gaps. You can use a brush to just move it into all the margins, or use a mylar strip pull through or whatever to drag it through, however you want to do that, and then polish it. But what it means is you're only trimming excess and getting rid of excess. So you're not, the actual shape of the restorations is dictated by your digital mock-up, if that makes sense. Okay, right. Okay, cheers guys.